Whichever fluid is chosen, it must be warmed prior to administration. Rapid infusion systems that use large bore tubing and rapidly warm fluids are invaluable during the massive transfusions. A convection forced air warming blanket and heated humidifier will also help maintain the body temperature. Hypothermia worsens the acid-base disorders, coagulopathies, platelet sequestration, and red blood cell deformities, and myocardial function. It also shifts the oxygen hemoglobin curve to the left and decreases the metabolism of lactate, citrate, and some anesthetic drugs. Amount of fluid administered is based on improving the clinical signs, particularly blood pressure, pulse pressure, and heart rate. Central venous pressure and urinary output also provide indications of restoration of vital organ perfusions. Inadequate organ perfusion interferes with aerobic metabolism, producing lactic acid and metabolic acidosis. Sodium bicarbonate, which dissociates into bicarbonate ion and carbon dioxide, may temporarily worsen intracellular acidosis because cell membranes are relatively insoluble to the bicarbonate compared with carbon dioxide. Acid-base imbalances will eventually resolve with hydration and improved organ perfusion. Lactate will be metabolized in the liver to bicarbonate, and H plus ion will be excreted by the kidneys. Hypotension in patients with hypovolemic shock should be aggressively treated with intravenous fluids, not vasopressors, unless there is profound hypotension that is unresponsive to fluid therapy. Coexisting cardiogenic shock or cardiac arrest. Some clinicians advocate a low dose infusion of dopamine, that is 3 mics per kg per minute, in an attempt to increase the renal blood flow. Regional anesthesia is usually impractical in hemodynamically unstable patients with life-threatening injuries. If possible, hypovolemia should be corrected prior to induction of general anesthesia. In unstable patients, also called the neuromuscular blocking agents, with general anesthetic agents titrated as tolerated. Mean arterial pressure more than 50 to 60 millimeter of mercury. In an effort to provide at least amnesia, commonly used induction agents for hypovolemic patients include ketamine and etomidate. Even drugs such as ketamine and nitrous oxide that indirectly stimulate the cardiac function in normal patients can display cardiodepressant properties in shock patients who are already have the maximal sympathetic stimulation. Intermittent small doses of ketamine, 25 mg every 15 minutes, are often well tolerated and may help reduce the incidence of recall, especially when used with concentration of a volatile agent less than 0.5 minimum alveolar concentration. Other adjuncts that may be useful in preventing the recall include the midazolam, intermittent 1 mg. Many clinicians avoid nitrous oxide entirely in these patients because of the possibility of a pneumothorax and because it limits the inspired oxygen concentration. Obviously, drugs that tend to lower the blood pressure should be avoided in patients in hypovolemic shock. The rate of rise of alveolar concentration of inhalation anesthetics is greater in shock because of lower cardiac output and increased ventilation. Higher alveolar anesthetic partial pressures lead to higher arterial partial pressures and greater myocardial depression. Similarly, the effects of intravenous anesthetics are exaggerated since they are injected into a smaller intravascular volume. The key to the safe anesthetic management of shock patient is to administer small incremental dose of whichever agents are selected. Shock that is refractory to aggressive fluid therapy may be due to uncontrolled hemorrhage that exists. The rate of transfusion or to cardiogenic shock. As for example, in pericardial tamponade or myocardial contusion, a myocardial infarction, neurogenic shock, as for example, brainstem dysfunction, spinal cord transaction, septic shock, a late complication, pulmonary failure, pneumothorax, hemothorax, or severe acidosis or hyponatremia or hypothermia. Secondary survey. In the secondary survey, the patient is evaluated from head to toe and the indicated studies, as for example radiographs, laboratory tests, invasive diagnostic procedures are obtained. The neurologic examination includes the evaluation of consciousness, pupillary signs, motor functions, and sensory loss. Fixed dilated pupils do not necessarily imply the irreversible brain damage. The patient should be undressed and examined for any hidden injury. The chest is inspected for fractures and functional integrity. That is flail chest. Diminished breath sounds may reveal a pneumothorax, which is an indication for chest tube placement. Similarly, distant heart sounds, a narrow pulse pressure, and distended neck veins may signal the pericardial tamponade, calling for pericardiocentesis. A normal examination does not definitely eliminate the possibility of these problems. Examination of the abdomen should consist of inspection, auscultation, and palpation. The extremities are examined for fractures, dislocations, and peripheral pulses. Now we come to the end of this session of lecture. I will come with the next one in the next session. Thank you.